Great. Well, let me welcome everyone to today's webinar, which is part of the Voice AI Summer School series. My name is Dr. William Hersh. I'm a professor at OHSU. I'm also a co-investigator in the Voice AI Biomarker project. The project is headed overall by our fearless leader, Dr. Yael Ben-Susan of the University of South Florida. So we're doing these webinars, one to provide more information and education around the use of voice biomarkers. But also these lectures are being recorded and will be part of the curriculum for a summer school that we're organizing that will bring together both computer and data science students as well as clinical students this summer at 4 different sites who will work at their sites and then interactively across sites, and will culminate in a hackathon in Tampa, Florida in early August. And the 4 sites that will be hosting students are University of South Florida, Cornell Weill Medical College, Washington University, and our institution, Oregon Health and Science University. This is, I think, the 4th or 5th in the webinar series, and our speaker today is Dr. Steven Bedrick, who is an associate professor here at Oregon Health and Science University in the Department of Medical Informatics and Clinical Epidemiology, which is where I reside as well. Dr. Bedrick's research explores ways to apply machine learning and natural language processing to problems of information access in biomedicine. And this is done through projects in assistive technology, automated linguistic assessment, and information retrieval of clinical notes. Steve is also a very seasoned, experienced educator. He teaches courses in our graduate program in areas such as natural language processing and data visualization. And he's well regarded as a teacher and attracts students from outside our program. Steve and I have actually worked together for many years. It's been about 2 decades when he showed up as a Ph.D. student here at OHSU. And I was actually his academic and dissertation advisor through his Ph.D. studies. When he graduated with his Ph.D. in biomedical informatics from OHSU, he took a postdoc position in the Center for Spoken Language Understanding here, and then joined the faculty. And then when that center was redistributed into other programs, he landed back in his original department, which is our department. And he's worked his way up through the ranks and is now associate professor. And Steve and I continue to collaborate, not only on this Bridge2AI project, but we also have an R01 grant that's focused on information retrieval to identify patient cohorts from electronic health records. So his topic today will be voice-based biomarkers through the lens of validity, and I look forward to hearing it, and I will hand it over to him.
All right, thank you so much for that very, very kind intro, Bill. I cannot believe it's been that long, but you're right, it has. All right, so I'm gonna share some slides here, and at this point I can no longer see the chat or anything useful like that, so hopefully everyone can see slides. Actually, Bill, can you thumbs up if you can see the slides? Okay, awesome, cool. Right, so thank you again for that wonderful intro. Hi everybody, it is a real pleasure to be here. We'll be talking today about voice-based biomarkers and what we mean when we talk about ways that we can validate them through a validity lens. So I'm going to start with a really quick intro of me, but Bill gave a really good one, so I'm actually going to burn through that. And then we're going to talk about what biomarkers are, because that turns out to be an interesting question, especially linking them to using voice as a biomarker. What we mean by validity, a little bit about the intersection between machine learning and validity, a couple of case studies, and I'm going to hopefully end with like a so what, why is this important? So Bill already talked about me, so I'm actually going to skip this quickly because y'all don't need to hear me talk, but I am going to have a little disclaimer here. I'm not an epidemiologist, a psychologist, a metrologist, or a psychometrician, or an SLP. So what that means is what I'm talking about today, I'm slightly over my disciplinary skis on. So if you are any of those things, please feel free to correct us in real time if I get anything too horribly wrong. But what I do is a lot of evaluation and machine learning, and because of my clinical focus, I work with a lot of people who are in these categories. So I've kind of taken what I've been able to learn and put it together here. Okay, so biomarkers. On the Bridge2AI Voices Biomarker program, we throw the word around a lot. In sort of machine learning and healthcare, we talk a lot about digital biomarkers for this and biomarkers for that, but I thought it'd be useful for this talk to really like start at the beginning and just establish what a biomarker even is. So biomarker has very deep roots as a concept in traditional clinical research, so usually in a very interventional model or an epidemiological cause and effect model. And the sort of official definition, it's a characteristic that is objectively measured and evaluated as an indicator of either a normal biological process, pathogenic process, or some kind of pharmacologic response to an intervention. So some examples of the ways we use biomarkers and examples of biomarkers. A frequent use, right, of a biomarker is as a diagnostic tool for identifying patients that might have some kind of abnormal condition or disease. So an example of this is in diabetes, we use elevated blood glucose as a biomarker, right? Our bodies don't have a diabetes ometer that we can just look at and like see what's happening in our pancreas. We have to infer that by measuring something. So people have determined that you can reliably use blood glucose as a marker of that. We often use biomarkers as tools for staging or classifying things. So prostate-specific antigen level, of course, is a very famous one for classifying progression of prostate cancer. We can also use biomarkers as an indicator of disease prognosis, right? If we are treating a tumor and it shrinks by a certain amount versus some other amount, that tells us something about how well is the tumor responding to treatment and how likely is it to all work out okay. And then we can also use it as a way, use biomarkers to help monitor responses to interventions. So cholesterol and heart disease risk, right? If you're trying to improve someone's heart disease risk, you might do a thing, and if their cholesterol goes down, we might determine that means they have less risk of that. Some other relevant things that get thrown around with biomarkers are words like clinical endpoint. So what I was talking about before with, heart disease, right? That's a clinical endpoint. That's a characteristic or variable that reflects how a patient is feeling, functioning, or whether they're surviving or not. These are going to be distinct measurements or analyses that are observed that reflect, the thing we care about. So usually these are going to be like an endpoint. It's the thing we actually try to measure. Biomarkers are sometimes used as surrogate endpoints, and these are going to be things that are intended to substitute for a clinical endpoint. So frequently, like I said, there's not a diabetes ometer, right? We need to have some other thing we can measure as a surrogate. It's expected to predict clinical benefit or harm or lack of benefit or lack of harm based on some kind of scientific evidence, right? So not all biomarkers can be surrogates, and not all biomarkers need to be surrogates. You might have already kind of been thinking about everything I've been talking about so far, where I'm using a lot of words like causing, linking, this all hopefully makes us think about that old phrase, correlation is not causation. Biomarkers are generally, when we measure them, usually they're measured as a correlation. We want to use them as a causation. And so that's sort of the tricky part about biomarkers. There's this famous quote, a correlate does not a surrogate make. So not everything that we can measure that is a useful biomarker can be a useful surrogate measure. So to dig into this, we're going to introduce some sort of concepts that we're going to come back to a lot today, and that's a causal pathway or a causal diagram. So an intervention very well might affect a biomarker. That's very different from demonstrating that it actually is telling us about the clinical endpoint. So here's a causal diagram, and this is a causal diagram about the relationship between someone's HIV status and the likelihood of mother-to-child transmission. And we don't have a dial that can measure how likely transmission is, right? We have to infer that. A common way to infer someone's disease burden is with like a biomarker like their CD4 count. So you might think that if someone has a high CD4 count, they'd have a high likelihood of transmitting. You might also think about having some kind of intervention, right, based on that observation that says, oh, well, if we can get their CD4 count down, perhaps by, doing a high dose of interleukin-2 late in pregnancy to get that CD4 count way down, maybe we'll have reduced the likelihood of transmission from mother to child. Unfortunately, that's not actually how that works. And the reason it isn't how that works is because CD4 count is not actually on the causal pathway, right? What affects mother-to-child transmission or maternal transmission is the actual viral load itself, which may or may not correlate with the CD4 count, but it's not actually on the same causal pathway. So we can do whatever we want to the CD4 count. That probably won't actually change the viral load. And there were a number of attempts to do things like this that didn't work. Another example, going back to what I mentioned earlier, PSA. So PSA is a fine choice if you want to assess the prognosis for prostate cancer or stage something, at the time that it's diagnosed. But it's going to be unreliable for determining clinical efficacy of an intervention, right? Because it sort of is ancillary to the actual tumor burden. It's related, but it's not on the causal pathway. So you might do something that changes the PSA level that doesn't actually affect the tumor burden. And some disease processes have complicated multidimensional causal pathways that makes all of this even more confusing. So, here is a case of, myocardial infarction and say 30-day mortality as our endpoint. We might make some change to affect a biomarker that's related to blood flow. And you can imagine a lot of different causal ways that, changing that blood flow, might impact someone's 30-day mortality, right? But there's also a lot of other things that it might affect. And there's a lot of other things that might affect the 30-day mortality. And so in cases where there's like an unclear mechanism or unclear mechanistic relationship between the blood flow, in this case, the biomarker that we're measuring and the actual endpoint, a given biomarker, may or may not be a useful useful surrogate. And this can actually lead to false negatives. There was a study on chronic granulomatous disease, sorry if I butchered that, where there had been some very significant evidence that like interferon gamma might be a good biomarker for a relationship between the disease and recurrent serious infections, but the actual intervention they were doing, or rather did not. It turned out that it was not a useful biomarker, and it led to a false negative about the actual intervention they were working on, because the biomarker didn't change the way it was supposed to. The intervention was working on a different causal pathway, and they missed it. There have been cases of false positives. This is all about the sort of mechanism of how of why correlations aren't causations, right? And then there's other cases where we've got off-target effects, right? An intervention, yes, it's affecting the biomarker. The biomarker is on the causal pathway to the endpoint, but the intervention is changing a bunch of other stuff too. And the intervention might be having other effects that are not really reflecting in the biomarkers. There was a classic example, was a study that was trying to suppress arrhythmia following a myocardial infarction, with an endpoint of post-infarction sudden death, because they correctly noticed that arrhythmia, was someone who had arrhythmia after an infarction was likely to die. So they thought, okay, if we can do something to get that arrhythmia down and measure arrhythmia as a surrogate, we'll have a way of we'll be able to use the reduction in arrhythmia as a biomarker for sudden death. That turned out not to work because the things they were doing to reduce the arrhythmia had other impacts that led to death, that had nothing to do with the infarction itself. They're about the thing. So they did in fact reduce the arrhythmia, but it didn't result in what they're wanting. So biomarkers are tricky to go from correlation to causation, and that's kind of a bummer because we often want that causation. Now, talking about voice biomarkers, something I've noticed is that people frequently talk about voice biomarkers in sort of what I sort of categorize as two broad categories of biomarker, right? So one is people are measuring specific characteristics of the voice. So fundamental frequency, features like jitter and shimmer, something like voice onset time or a pitch contour. These are like specific concrete features that we can characterize of the voice. And then we're using those directly in like a very classic biomarker sense, right? Where we're saying, we'll see an example later on, but we're saying, we have some reason to think that the pathogenic process would impact the fundamental frequency in some way that's really linked to the actual endpoint we care about, and so we're gonna measure that. And then another way people talk about voice biomarkers is a kind of what I'm calling a predicting stuff from voice model, and that's a more sort of machine learning data sciencey approach where we take a large number of features. We don't have an underlying theoretical justification for why these features and not other features. We're just using them and we're trying to predict a thing. And sometimes people call those bags of features or bags of derived features a biomarker. But as we can see, that's like a little bit different from like a classical biomarker, right? We don't have, a real solid understanding of like what pathogenic process is leading to that. And then these get used for a very, very wide variety of purposes. People have tried predicting everything from, or using them to predict, very, very concrete clinical features of, how is someone responding to a speech therapy intervention, all the way to, we'll see an example later of predicting, all-cause mortality based on voice features. So, pretty much the whole gamut from really concrete to super, super high level. So how do we validate biomarkers? How do I know if I have a good biomarker or not? There's first we should talk about what makes something a valid biomarker. So there's an actual definition from the FDA that if you want to use a biomarker as a surrogate for in your drug trial for your clinical endpoint, you have to validate it to meet certain criteria from the FDA. And they talk a lot about, it has to be measured in an analytical test system, very laboratory test focused or genomic test focused, with well-established performance characteristics, for which there's an established scientific framework or body of evidence that tells us what the clinical significance of the test is telling us. So well-established performance characteristics, right? We have to actually understand, how is this biomarker working? How does the test, how do we characterize its performance? And then we want to have an actual scientific understanding, usually with some kind of notion of the clinical significance. You can kind of see how from my voice biomarker example earlier, if we're measuring like a concrete, clinical feature of a patient, that's a little bit easier to meet this threshold than if we have some kind of opaque bag of features that we've assembled and gotten out of the computer somewhere, right? That becomes a slightly trickier lens to talk about it in. Now, it's important to talk about that, to say that like validity, we talked about it as though it was a single property sometimes of a biomarker, but really it's very difficult to talk about the validity of a biomarker without also talking about what we're going to do with it and how we want to use it. So you might have a biomarker that for one use is sufficiently valid in that it's sufficiently understood and we have a reasonable, understanding of what it's doing. For another use case, it might not be. And so people sometimes talk about, the biomarker was validated for this kind of diagnostic purpose, but maybe not some other one. Things to think about when validating. I should also say it gets broken down into two steps. First, validation, right? That's the process of coming up with what I was just talking about, the assessing its performance characteristics, determining when it's going to work, when it will be reproducible. People also talk about qualification of a biomarker as the process of actually linking it back to the underlying biology. All right, points to consider when doing validation, or another way to think about it is what kind of questions do we answer? The actual things that we usually are trying to measure are things like sensitivity, specificity, the accuracy with which we can make the assay, that's sometimes called like its measurement validity, pharmacodynamics all come into play. Another less concrete thing to think about with biomarker validation that gets thrown around is this great acronym, the OMERACT filter. This actually comes out of rheumatology, but it's made its way outside of rheumatology into other biomarker things. And they zoom out a step and they break down validity into 3 dimensions. They talk about the truth of the biomarker. Does it measure actually what it's trying to measure? Is the result unbiased, et cetera? Discrimination, does it give us good discriminatory power between, people with the thing and without the thing? So not just can we measure it, is it measuring a real thing, but does it actually have predictive power? And then feasibility, right? How well can we have it be put into practice given, time constraints, money constraints, all of those other things. And you can imagine how each of these we could potentially address with some of the more concrete classical measures like sensitivity and specificity. But I like the OMERACT filter because it has a zoom out a little bit. Now, you may have already noticed that I'm throwing around the word validity a lot and using it in a lot of different ways. You'll find that people in different fields use the word validity to mean a lot of different things. And people sometimes even have, very specific kinds of validity that means different things to people in different fields. So the most useful model for validity that I've ever run into is the sort of psychometrics inspired measurement science model that we're going to talk about now. And this is used frequently in epidemiology and psychology. It's used much less frequently in machine learning. And it is often used in diagnostic test development, but not as much as it could be. And The reason I want to talk about it with you guys today is because when we talk about voice biomarkers, we're almost always talking from a machine learning standpoint. And these are some ideas that I think could stand to penetrate a little bit more deeply into the machine learning world. So, like I said, this is coming out of psychometrics. The classic definition of validity then from Cook and Campbell, who sort of wrote the book, it's the best available approximation to the truth or falsity of propositions, right? Usually when we talk about the propositions we're talking about here are causal assertions. So we're starting to say that X is causing Y. Another way to break that out, because causation is very complicated and can be, you can have multiple causal pathways like we saw earlier. We would actually, a better way to put this is that A is on the causal pathway between X and Y in the case of a biomarker. Again, talking about validity, right, on its own is not very meaningful. Like it really does come down to the situations that we want to use it in. If the statements, inferences, and conclusions, those are the things that we can validate, right? A given biomarker itself, as long as we're measuring it accurately, on its own isn't telling us anything. And so it's very hard to talk about whether it's valid or invalid or insufficiently valid or less valid than what those guys are doing over there. Really, we have to set it, in its larger context and what the larger reason for doing it is. Another important dimension is sort of what the goal of the research we're trying to do with the biomarker is. And this gets also to the kinds of conclusions and assertions we can draw from it. So 3 main kind of high-level purposes for even doing research in the first place, right? First is demonstration purposes. I should say, before I get into more of these details, having clarity about which reason we care about. The reason I'm bringing this up is it's very important to be clear about like what our rationale for doing the research is in the first place, because that's what's going to determine what kind of validity we need to be worrying about and whether or not we can determine it or not. So demonstrative research is really just about empirically establishing the existence of a phenomenon or a relationship. And frequently with biomarkers, this is the level we're trying to get to, right? We are trying to show that there's a difference in F0 between people with and without Parkinson's disease, or we're trying to demonstrate the existence of a correlation between smoking status and lung cancer, right? So this is, one kind of level of research, and I'm laying this out as though it was a hierarchy. It isn't really. These are like qualitatively different reasons to be doing empirical research. The second is for causation, right? Not just showing that there is, people who smoke also sometimes get cancer, but that like it's being caused by the smoking. And usually this is, done so that we can show that having some intervention will actually reliably produce a subsequent change. This implies like a very different level of detail and pain than demonstration research, but that doesn't say that demonstration research is not, of course, very important on its own. And then explanatory research. Explanatory research, we might be trying to figure out, intervening. Basically, it's about the causation is about that something is causing something else, and the explanation is about how, right? Why and under what conditions does X cause Y? Can we figure out what's moderating or mediating that behavior? So, in order to disentangle all of these, we are going to be going into a whole Tower of Babel of different vocabulary for different kinds of validity. You can see how these are different kinds of research that all have different dimensions of validity that might be important for different parts of the process. So again, this varies dramatically from within across fields how they talk about this. It's also evolved over time. So books from 50 years ago talked about it differently than we think about it now. But language, we're stuck with the language that we have. And so again, going back to psychometrics, their taxonomy I find extremely helpful. So beginning with internal validity. Internal validity is a way of asking, or when we talk about internal validity of an experiment, we say, do the findings hold within the context of that experiment's research settings, right? With the subjects that they had, with the methods that they had, did they actually measure, Did they measure something, or did they get a spurious effect of some kind, right? Was there confounding? Was there a third variable interacting in some way? Did they have some kind of data problem? Did they actually observe what they thought they observed, right? So that's one very important kind of validity. Another important kind of validity, though, of course, is external validity, right? Would the same findings hold across a different setting, different subjects, different methods trying to measure the same thing, right? Can somebody else measure the same thing and get the same answer about, whatever we're concluding between X and Y? If somebody else tries to measure it, what would they get that? So when we talk about external validity, we're often talking about generalizability, right, to new populations, to new domains. Both of these are different from construct validity, right? Construct validity is the extent that we can generalize from one study's finding back to its underlying, theoretical basis, right? So we measured a thing. We all agree that we measured a thing. You went out and measured the same thing on your data. Now, is it what we actually think we're measuring? And we're going to dig into each of these a little bit more detail. So internal validity, right? More formally, we've got some dependent variable, and when we changed our independent variable in some way, right, and we saw a change in our dependent variable as a result of that intervention, brilliant. We want to know if that variation in the dependent variable was actually caused by our change or by something else entirely. So here's where we worry about moderator variables, selection bias, randomization issues, all of those things that we learn about in research design class that can mess with us. Usually when people talk about internal validity, they're talking in terms of causal inference, but there's no reason why we can't use this for descriptive research as well. The sort of language of internal validity and talking about internal validity threats separate from external validity threats is very, very helpful. External validity then, right, we're looking across settings. So there's a lot of different ways to kind of talk about external validity, but ones that come up a lot are robustness. So that's, replicability across settings. From a voice standpoint, if we go and use a different microphone, or if we do this on a different patient population who aren't from Portland, right? Are we going to get the same finding? Are we going to get, if I say F0 is a great way to differentiate people with Parkinson's and without Parkinson's, and you go measure it in your clinic on your patients and also measure F0, and you don't use my code, you write your own code to compute F0, and you get the same answer, right? That we demonstrate robustness. Now, just because we can generalize across populations, it's important to remember that doesn't actually tell us that it will generalize to any particular population, right? So because I've shown that it's good for Parkinson's across our populations, that doesn't mean that it is a magic feature that will tell us about some other neurological disease, right? It might be suggestive that it could be a valuable feature, but on its own, it's important to keep in mind the constraints of what we're concluding. And then another important one is ecological validity, right? Ecological validity is about, how well will an effect that's demonstrated in one setting, turn up under everyday, typical, normal conditions out in the lab, right? So background noise, naturalistic sampling, multiple speakers. It is extremely common to have a biomarker, or especially in voice, to have a voice biomarker of some kind that works beautifully in the lab, and then won't work in the field because it doesn't work if there's two people talking, or it doesn't work if the TV's on in the background, or it only works if you hold the microphone in a certain way, but if the microphone's held somewhere else, it doesn't work, right? Or variability is a problem. It also comes into play when there's clinical workflow issues of data missingness. It's very common to have something that works on a beautiful data set with complete data, but in practice, when people don't do all 4 sessions and you only have 2 sessions, it falls down. So that isn't about the internal validity of the study or the finding, right? We have shown that F0 is very valuable for Parkinson's disease staging, but it does mean that it's less applicable out in the real world. And that brings us to a third dimension, which we're not going to dig into too much. I should have also said this part. Our PI likes to say that life is not about exclusion criteria, and this is what she's talking about, the importance of ecological validity here, right? That what we do on this Voices of Biomarker project, the reason the data set that we're building is being built the way it is because we want our data set to be able to help develop ecologically valid measures. Whatever we build with them, we want them to be useful in the real world. And so we're collecting data that is, yes, in a lab setting, but it's over a very diverse population. We've validated that the way we're collecting it is feasible to do in a real world setting. And they put a lot of work towards establishing ecological validity. And then the third dimension is relevance. Are the findings actually useful for solving a real problem. And that's related but a little bit different to ecological validity. And we'll see an example of that here in a little while. All right, and then construct validity. Construct validity is maybe the trickiest of them. How do we measure the unmeasurable, right? Frequently, the things we want to measure involve very abstract phenomena or states, mental states or physical states that are very hard to measure, like mood or attention span or socioeconomic status or something vague like heart function, right? These are unobservable theoretical constructs, right? And in order to measure them, we have to somehow operationalize them into something tangible. So if we want to measure mood, or if we need some kind of instrument to ask people about their mood or otherwise measure it. If we want to measure attention span, we need to come up with some kind of task, that requires attention span that we can use to assess. As an example, here's what should be a very, very simple thing, height. This is what's called a representational measurement, in that it's a thing that is in principle actually directly measurable. We have a yardstick, it should measure height. In practice, though, when we operationalize a construct, we're making a model, right? We're making a procedure, or we're making all kinds of assumptions, and even something very, very simple like height. We're making procedural assumptions. Do shoes count towards height? Does somebody's hair count towards their height, right? That that might affect depending on our patient population, whether their hair counts or not, could introduce different kinds of demographic bias. If we don't nail that down and have that be part of our procedure, that yes, it counts, no, it doesn't count, that's going to be an issue. If people come in wearing different kinds of headgear, that might make measuring it challenging and might introduce weird biases into our data. So even something very simple like height is there. What if someone's in a wheelchair? How do we measure their height then? We could measure their sitting height, their standing height. Depending on why we care about the height, one or the other of those answers might be more effective, might be more important, right? If we're needing to estimate how high a counter needs to be, for a clinic, right? We would need to think about one of those versus the other. So, and then no measurement is error-free. If I measure versus you measure, we might measure a little bit differently. So operationalizing constructs, even very simple constructs, is hard to do, and requires like a lot of care and a lot of thought. A more complicated example would be like, say, socioeconomic status, right? We talk about this in a lot of research as though it was a single thing, but of course it's not. It's a million things. It's what Hannah calls a pragmatic measurement, meaning it's very, very, very task and context dependent how you operationalize it. If you have two studies that operationalize it differently, they could be measuring just completely different things, right? So simplest way to measure something like this is you pick a proxy measure, right? Something that you think should capture many of the features of SES. And so a common one might be, say, 30-day income. Funny story about that. How you define 30 days really matters. Just saying 30-day income applies some kind of temporal pattern to someone's income. And there was a really famous case where the British government had like a social benefit program that was based on your 30-day income, but the way they measured it, it could totally be possible that it was related to the time that you applied for benefits. And depending on what your sort of pattern of getting paychecks was, you could end up in a state where the 30 days included 2 pay periods, right? Which means that on paper, you would look like you had twice the income you actually do, and people were actually getting like really badly screwed over by the system because of that. And that's, it really caused major, major problems. And you could look at this like an internal validity problem, in that, the way that they set up their measurement was flawed, and that they were, they should have found a better way to set up their measurement, and they were getting this weird measurement bias. I think this is actually like a construct problem, like it's baked into the idea, baked into the definition of the measure, of the operationalization of the measure, is this notion of a 30-day window, and that, for some populations, like that might not be the right way to do it. So when we talk about construct validity, more formally, what we mean is that the validity of the inferences, we're talking about how valid were the inferences that we made when we linked our construct to how we chose to operationalize it. And that tells us in turn, how justified are we in drawing conclusions back to the theory, right? If I do a study about that 30-day income thing, I can say all day long that I found something about people's 30-day income, but what I really want to be talking about, and the reason I'm doing it, is because I want to link it back to SES. And how valid is it for me to make that link is what we talk about when we talk about construct validity. Questions to ask when establishing construct validity. Does the operationalization capture everything important that we think we're measuring, right? With the 30-day income thing, are there other dimensions of SES that we care about that isn't capturing? Are our measurements plausible, right? We measured some stuff. Does it make sense that everybody, is 10 feet tall? Maybe there's a problem with how we're measuring, how we decided to measure. Do the measurements correlate with other measurements of the same construct, right? If I have a bunch of some other way of measuring SES, right? If my measurement correlates with some other measurement, that's probably a good thing. If it doesn't, maybe there's something I need to worry about. And then it's good to look and see, do they correlate with anything else that maybe we don't think is related, right? If my measure of SES also correlates with the phase of the moon, that's probably not a good sign. And then it's good to think about the impacts of choosing this measure, right? If we decide that this is the measure we're going to use, how might that impact things down the road? A major risk to construct validity generally is what's called the mono-operation bias. So any single operationalization is necessarily, it's underrepresenting that construct, right? We're making a model of the more, we've got this big multifaceted theoretical thing called SES, or voice quality. And we're going to pick a couple of things we can measure to operationalize it. And we know that is approximating and underrepresenting it. And so we know that's missing out. So it's really important to do what's called conceptual replication sometimes, and try multiple operationalizations to get real construct validity. Yeah, we're making a model, so we're throwing things out. More formally, ways to talk about all of this are things like the phrases you might hear are content validity. So that's how thoroughly does our measure capture everything about the construct. Convergent validity, right? How well does our measure correlate with other measures of the same construct? And then discriminant validity, right? How well does our measure, or whether does our measure, our measure should not correlate with things that we don't think should be related to our underlying construct. And this is where you get, measures where, we think we're measuring risk of recidivism, but it also correlates with race, right? Which we don't have any reason to think is related to risk of recidivism. And so that's a failure of discriminant validity when that sort of thing happens, right? Some other really important kinds of validity that come up are face validity. So how plausible does a given model just seem based on what we know about the phenomenon and the science? This one is very subjective, right? It's you never want to rely on it, but you also shouldn't ignore it. Sometimes, especially with voice biomarkers, we see stuff, and we'll see an example of this where personally I look at it and I'm like, I just don't see what the face validity is. Like, I believe you that it's measuring a thing, but like, why would that do it? And other times we see studies with really, really strong face validity, and it's never good to rely on it because it is subjective, and it brings when we're bringing our own ignorance and our own bias to it about the ignorance of the science and bias about what's relevant or not relevant, but neither should it be totally ignored. Criterion validity gets at how well does our method correlate to another observation that is measuring the same thing. Meaning like another actual observable, measurable thing. So a good example there is a blood pressure cuff reading versus intra-arterial blood pressure, right? So they're both measuring blood pressure. They should be very, very strongly correlated to each other, right? Another classic example is Apache scores and ICU mortality, right? Now the first one, the blood pressure example, is what's called concurrent validity. So simultaneous observations that should hopefully be very predictive of each other. And then predictive validity is criterion validity against a future observation. And these are different dimensions of the same thing. So that was a lot of kinds of validity. The important takeaway here is that validity is a lens. It's not a set of hoops to jump through. People sometimes talk about validity as though it was like a state. You're either valid or you're not. And I think that's a little bit reductionist. For many applied scenarios, we don't need construct validity. Like, that might not be the important thing for some scenarios. Sometimes just knowing about the existence of a reliable causal link might be sufficient. That's sometimes called utilitarian causation. And then Jacobs and Wallach, in their fabulous paper where I got the height example from, they say they emphasize that a key feature, not a bug, of construct validity is that it's not a box to be checked. Construct validity is always a matter of critical reasoning and a matter of degree and meant to be worked through. So the value in thinking about validity as a lens, not a set of hoops, is now we get to talk about, it helps us talk and to think really clearly about what we're trying to actually do with our research and figure out in a really informed way what we do and don't need. So It is not a gold star as much as we love giving gold stars to things. Okay, now let's talk machine learning and validity, and I'm going to have a little Festivus airing of grievances here. In machine learning, I will sort of just say that we don't really talk about validity very much in the sense that I've been talking about it in machine learning. We talk a lot about evaluation, right? And if you really squint, evaluation is usually done with the sort of big picture goal of validating. But we usually kind of get to the point of computing a metric and stopping, and we usually don't really have good, well-motivated, good motivations for why we chose the metrics we did. We choose the metrics that other people did because those are the metrics everyone uses. And our justification for this is usually that we don't claim to be making causal inferences. We usually say that we're just doing correlational research. And so we just kind of punt on these questions of validity, which I think is misguided. It gives us a lot of bad habits. Cargo cult evaluation where we use F1 score because everyone else uses F1 score. And it just causes a lot of sloppiness and a lot of problems. And also, we can say all we want that we're not doing cause and effect research, but it's very, very common to use a correlative model in a predictive way in a lot of applied machine learning scenarios, right? And every headline you've ever see about AI can predict X from Y, right? Like the reason they're excited about that, and the reason the authors, universities, press offices made a press release saying that they predicted, X from Y, is because they want to make some actionable model or design some intervention, something that doesn't need causation. So it's a little naive of us in machine learning to discount that likelihood. So some things to think about as machine learning practitioners. Issues of dataset creation and sampling and outlier removal. These are all really, really important when we think about them in terms of our internal and external validity, right? We talk about them in terms of messing up our results, but we should be a little more concrete than that and think about, are we affecting our internal or external validity? And then we can decide, okay, the way we did this outlier removal is fine for ensuring internal validity for our study, but it is going to limit our external validity, and we should be really transparent about that and report that, right? Same for choices about cross-validation, regularization. Both of those things are usually designed to improve internal validity, right? And that's good. We can talk about it that way. Something that comes up a lot in voice as a biomarker is we rely a lot on feature standardization and normalization. It's really important to do this after we do our test train split and do our standardization separately on our splits. Otherwise, that's data leakage, and that's bad. So this is especially bad for us in voice data, and it's just a thing to watch out for. Data acquisition plays a very large role in validity and machine learning. So things like microphone choice and placement and recording settings, right? And the instructions we give to participants and our data labelers, these are all things that are going to have big impacts on our external validity of our machine learning research in ways that we don't always think about. As an example, two labs do a sustained vowel test, but do them slightly differently, right? Give slightly different instructions to the annotators or use different kinds of audio acquisition. We might actually get different results, right? Even though we're nominally measuring the same thing. That's the thing to watch out for. This is especially important when we are dealing with opaque and learned features, right? With a lot of the deep learning methods, we end up with these features that don't generalize, and this is why, right? Because we've got threats to our external validity that we didn't account for. Okay, so I've got 15 minutes still, so I'm going to go over a couple of examples of voice biomarkers in the wild. Before we start, I want to really emphasize this is not me saying that this paper experiment is good or bad. Validity is a lens, not a sticker, right? What this is about is I want to use the tools that we've been talking about to help us ask some questions of these two use cases of voice biomarkers. We're going to ask questions like, given the study design, what inferences can we make and what might not we be able to support? And what limitations do we need to worry about and what don't we need to worry about? And then if we wanted to, that should be B, not bow. How reasonable would it be to use the biomarkers they've identified on something new, right? If I read the paper and I say, oh, that worked well for them, like maybe that feature will work well for me. How reasonable is it for me to be making that leap? So the first paper I'm going to talk about is an oldie but goodie. It's a classic paper on acoustic features, characteristics of Parkinsonian speech. It's from 2004. So it's fairly early on in the voices of biomarker research world. This paper lays out a very, very strong neurological rationale for why acoustic characteristics of speech might be relevant. So in Parkinson's, there's a decrease in dopaminergic input, which results in dysregulation of basal ganglia. Oh my God, spell checker had challenges for me today. And that is going to result in motor deficits, which we know are going to affect respiration, phonation, and articulation, right? And that's going to have a big impact on speech motor control, which will lead to acoustic changes, right? So there's like this fairly clear, I think very like well motivated model here for why looking at acoustics would be relevant. So they chose 3 features. They looked at variability in the fundamental frequency in a free speech sample, vocal onset time, and then percent pause time. So vocal onset time being when someone starts speaking, how long before vocalization begins. And the endpoints, they looked at 2 different endpoints. They looked at changes in the preclinical symptomatic phase, or rather before the clinically symptomatic phase, changes over time. They had this very interesting data set where they had that data for some participants. And then they also looked at characterizing the change as the disease progressed post-diagnosis. So they had this very unique data set where they had a handful of people who are public figures, where they had a lot of recordings and interviews of people before they were diagnosed for years and after they were diagnosed for a while, and after they were treated for a while, where they could actually look at this. So that's kind of cool. And they found, sure enough, that F0 did have a change during the pre and post-treatment phases. And also voice onset time did have a change, and healthy controls did not have a change from the same longitudinally matched time sample. So let's look at our dimensions of validity on this. So for face validity, I think they had an extremely strong face validity for what they chose, right? Very strongly linked to the underlying pathophysiology. We can draw a causal pathway, right? That makes a lot of sense, and it's clear what's going on. There's, other things that might impact it, but it's pretty solid. For their internal validity, they had very well characterized feature extraction, right? The algorithms they used were very well understood and well behaved. They had a very well characterized process for sample selection. Given that they identified the participants, which has some limitations we'll talk about, the way that they identified which voice samples to use and which parts of which voice sample to use was very, very robust and simple. There was a specific frequent utterance. They used the utterance to, as in the number 2 or the preposition or whatever, for voice onset time. And so that was really, really straightforward and clean. For voice onset time, they had humans annotate when voice onset started and stopped. And for that, that could have been a risky thing to do. But in practice, they had multiple data labelers and measured that they had very high inter-reader agreement. So I give them a green check for internal validity on all of this. Like I believe that what they're measuring is what they think they're measuring, and the effect they saw is real. So awesome. Let's talk external validity. They had a tiny, tiny, tiny sample size, like single digits. So that I give the little monocle emoji to that one. But they were very, very open about that fact, right? So that is not a flaw in the study. That is a limitation to the generalizability to new people, right? They also had a convenient sample of audio recordings, which whatever they could find from people's public speeches and interviews, which is convenient samples are always questionable for generalizability. Now, that said, the recordings they had were longitudinal and very deep, right? They were repeated over many years for each person. They had many repeated samples. So that actually is a point in the favor for generalizability, right? Because they, yes, it was a small number of people, but they had a lot of data points collected at different points in time in different settings. So that's actually a positive sign. And then the recordings came from a lot of different microphones. From like an acoustic standpoint, this makes me a lot more confident that whatever they're measuring would actually be applicable in an ecological validity sense, right? Because clearly they were getting a good signal from a wide variety of kinds of recording settings. Some limitations for external validity and some areas of strength. And then construct validity was less of an explicit concern for this kind of study, just because of how they were setting it up. However, we can still go back to this kind of model that they had and have a discussion about the content validity of the things they measured, right? So like F0, voice onset time, were there other things that they should have been measuring? Are there other features that would get at disordered Parkinsonian speech that might be missing from this, right? So that's worth thinking about. And we could have also we can also look at convergent discriminant validity, and I would say the authors actually do talk in the paper about how their second experiment with the post-treatment, they use that as a convergent validity with what they found in the first experiment. So they actually use this framing of convergent validity here, which I think is really cool. Okay, the second paper I'm going to look at real quick is this one. It's much more recent. I'm choosing this one where they looked at their endpoint was hospitalization and mortality. This is I did not pick this paper for any particular reason at all. It's neither good nor bad. It's just not, it's a very good example of a modern data science-y kind of workflow. The first one's a good example of a traditional voice biomarker study that takes a very classical epidemiological design. They may as well have been taking a blood draw, and that study would have been identical, right? This one is different, right? So this one, they are doing a data science-y workflow. So it's secondary use from a hospital call center recordings. They had people who were calling into the hospital. They took from those recordings a grab bag of acoustic features. They had some software package that could extract like 50 things. They ended up with like 600 features, which they then did a series of post-processing, like a dimensionality reduction down using 8th order moment analysis, and then did feature selection on the resulting couple hundred of features to get down to 223 opaque, uninterpretable, meaningless features. Their endpoints were inpatient hospitalization, then all-cause mortality. They had a very large sample because this was, a very different kind of study than the last one. They had thousands of patients with and without congestive heart failure. And then they computed quantiles of their biomarker and looked at survival analysis of all-cause mortality, and found that yes, one of the biomarkers, there were differences between the quartiles. They also looked at hospitalization and found the same thing, right? That there were differences. So they draw some conclusions here. Okay, face validity. To me, it is not entirely clear why voice would be informative for these endpoints, right? They took a total grab bag approach to feature selection. There was everything they could compute and then did a bunch of math on it. The model of the causal pathway between the disease, congestive heart failure, our biomarker, this mess of things that we've measured and ran through a wood chipper, and our endpoint is very opaque. I'm not saying there's not, like, we couldn't draw a causal pathway, but there'd be a lot of branches on that pathway with a lot of other things coming in and going out, and there could be a lot of relationship. So any explanation is going to be very multifaceted and deep. This is not uncommon for a lot of projects using machine learning and data science approaches. It's not like the kiss of death or anything, but it does mean that there's a lack of theory. This is like a frequent complaint from epidemiologists about data science approaches. So I will just put a shrugging emoji on this. Like to me, this has some weak face validity, but I'm not going to say like we shouldn't do it but it does mean that it's got maybe a higher burden of proof for how much stock we should put in the results. Internal validity, all the stats they did were automatically computed, right? So one strength of this kind of research design is that much of the experimental procedure is automated. So a lot of the traditional ways you can have threats to internal validity are weaker. However, the data were manually segmented and concatenated from phone calls. They said the process was robust and only marginally affected by disturbances, but didn't go into any detail. They didn't compute inter-rater agreement or do perturbation studies or anything like that. The process for feature selection, it may or may not be repeatable if you had a new sample or revisited it. We don't know if that process would result in the same features. Then the models they use cross-validation, and that definitely helps a lot. The endpoints were validated using EHR data, and in the paper they talk about some of the issues that led them to have in terms of data completeness. It also means that the endpoint status is related to a lot of workflow and informatics issues in that hospital. There could have been temporal changes in terms of how documentation was done that could actually be messing with that result and confounding it in a way that you got to watch out for. external validity. The authors themselves actually report several very important limitations. They're very upfront about the limited claims. They're not making very much of a claim to external validity, which again, back to what I said earlier, it's important for study to have clarity about what are you even trying to do. They aren't claiming that they have external validity, right? They say it's a retrospective design on a very specific population in terms of the language spoken and the diagnosis, very limited explanatory power, and because of the study design and because of incomplete data, and limited what people in the ecological validity sense sometimes call relevance, because the study design didn't allow them to have any kind of thresholding cutoff for the biomarker because of how they set up their samples. So they have these quartiles, but that's different from having like an actionable threshold. So that limits what it might be able to do in the real world. And then they don't talk about this, but I worry about ecological validity. They're working on telephone drive data and then doing all this feature extraction, running it through a wood chipper. I don't know how would that work on non-telephone data or a different phone system? I don't know. Now, I give the authors a gold star though because their limitation section is actually extremely well written and thorough. So it's great. Okay. In conclusion, so what? What does this kind of thinking get us? Well, my first point here is that it's now well established that many machine learning tools in medicine they underperform in the real world. There's a performance gap, right, when you try to deploy it. And there's been a lot of ink spilled about why that is. But I think most of the time, if we look at the root causes of people's explanations, it usually goes back to a failure of one of these kinds of validity, right? And knowing what kind of validity is in play helps us pinpoint what to do about it. So if it's a failure of ecological validity, maybe better technology will fix that problem, right? If we can get better audio recordings, or if we can do better processing on the audio or whatever, maybe better technology will help. If it's a failure of construct validity, if the thing that the model was measuring wasn't actually what it was supposed to measure, maybe more technology is not the solution. Like a bigger model won't get us out of the problem. So I think having clarity about what kind of validity is in play helps us maybe figure out how we can get things to translate and work better. And then a common practical question of machine learning is how good is good enough? And validity, thinking in terms of external and ecological validity and predictive validity can be really helpful for sorting that out. And then also thinking in these terms helps us spot problematic stuff out in the world. So this is from a lovely paper on Voices of Biomarker about sort of the causal pathway for a lot of different things to the acoustic features. And I'll just note that it has ideas and thoughts and mental states, and the pathway between mental states and what we can actually measure is very long and articulated and goes through a whole lot of steps. When someone tries to say that they have a biomarker that'll tell you about mood, an acoustic biomarker that tells you about mood, right now on the face of it, we have reason to believe there's low face validity for that, right? For how that works. So there's a very high burden of proof. So with that, I will stop talking and leave it there and open up the floor for questions. And I seem to have come in 1 minute under time, so that's exciting. And I'll be happy to take any audience questions or thoughts.
Yeah, we're at the hour, but we can probably go a few minutes extra. Are there any questions out there? There is a request for your slides, which I would also be
we can do that.
to see.
Yep.
Maybe Christy can send them out. Questions from anyone in the audience? You can either unmute yourselves or type it into the chat. Maybe I'll ask something quickly. It's really more of a comment than a question. The voice biomarkers and hospitalization. To me, another issue is we're so awash in data these days that you can probably I don't know how much they talked about testing any and every possible biomarker, and then they found one that had a correlation. Which there's potentially a role for things like that because maybe there is some feature out there that is associated. But on the other hand, it's like with statistical testing, p less than 0.05 means 5% of the time you're presumably going to be wrong. Did they describe things like that?
That's a very, very real problem. The way that they avoided that is they did their they used like an assortment of features. They didn't just use one of them, and they did some stats to try to like bring that dimensionality down. Then they went through a feature selection process that was I forget exactly what process they used, but it was one that was designed to try to avoid that problem. That they were trying to be robust to that. You know, I would be curious about, you know, how stable would it be if they perturbed their data set a little bit, if they resampled and ran through the same thing, would they get similar kinds of combinations of features at the end? But because that's definitely a thing of concern. I think the way they did it was actually just fine. I hope it doesn't sound like I was complaining about that paper specifically, because I think what they did was they did it fine, and they were really upfront about what they were actually concluding.
Yeah. Well,
But
and you know, if it can
there's
be
always a risk.
replicated in other places, you know, with other kinds of data, then
Exactly.
maybe they are valid biomarkers.
Yeah.
Any other questions out there? Okay, well, if not, I
Okay.
want to thank Steve for a great talk. I found it very interesting. And you know, you bring up a lot of points that are important as we look at developing voice biomarkers. So thank you all for attending, and have a great day. See you all later. Bye-bye.
Everyone.